welcome everyone. We're so glad to have you here. Whether you are joining us live or viewing this later as a recording, we are really glad to have you with us. My name's Naomi Hoffer. I'm the program manager for the UCSF Sherry Sobrato Brisson Brain Cancer Survivorship Program. And this webinar is part of our Living Well After Brain Cancer Treatment webinar series, which is a segment of our growing survivorship program in the UCSF Neuro-Oncology Clinic, whose mission is to enhance the wellness and quality of life of patients with brain tumors through a collaborative, multidimensional approach, focusing on emotional, physical, and cognitive health. Also part of the team, and here with me in the Zoom background, is our survivorship nurse practitioner, Alexa Greenstein, and our supportive care services community expansion coordinator, Mary Destry. And so you might see posts by both Alexa and Mary in the chat box. Today, we are addressing a very important topic to those living with brain cancer, and that is our brain functioning and its ability to heal. So we know that most people who receive treatment for brain cancer will experience some type of disruption in their thinking. And so this webinar will focus on what can be done to help mitigate that disruption and to optimize brain functioning. So today we'll be learning a bit about the scientific and functional definition of neuroplasticity. We will hear how brain cancer surgery and treatment affect brain function, as well as factors that support enhanced neuroplasticity. We'll learn what cognitive rehabilitation involves and some recommended strategies for enhanced cognitive functioning. And then we're very fortunate to have a survivor with us today to talk about her firsthand experiences with the cognitive changes and her road to recovery after brain cancer. If time permits, both she and Dr. Hervey-Jumper will be available to answer your questions. And as I said previously, please submit those questions using the Q&A function on your Zoom screen. And finally, as you see here, we'll invite those of you who wish to stay afterwards and continue the discussion to do so in our unrecorded after the show segments. We will give you instructions on how to do that at the end of this presentation. So now it's my absolute honor to introduce our featured speaker here with us today. Dr. Shawn Hervey-Jumper is Associate Professor at the University of California, San Francisco, and co-director of the Sherry Sobrato Brisson Brain Cancer Survivorship Program. He is a neurosurgeon researcher with a clinical practice focused on the surgical management of patients with brain cancer within functional areas using physiological mapping. In his research laboratory, he seeks to understand how brain tumor cells influence functional circuits and cognition. His ultimate goal is to better understand the mechanisms of cognitive impairments, thereby leading to novel treatment options focused on improving network recovery and thus improving cognitive outcomes for patients. Dr. Hervey-Jumper, thank you so much for being with us here today and helping us understand this concept. I will now turn it over to you.
Thank you so much. What a wonderful invitation. This is a great group. Give me a minute here to just transition over and share my desktop with you all. Okay. You should be seeing slides now.
Looks great. Thank you.
Great. Well, thanks. So again, my name is Shawn Hervey-Jumper. I'm a neurosurgeon here at University of California, San Francisco. You know, it has been just such a privilege to work with patients and researchers and all the staff here. And my interests have really lied at the intersection of cognition and brain cancer, both as a clinician and as a cancer neuroscience researcher. So we're going to talk about some important concepts today, and I hope to leave enough time for questions at the end, and especially, again, if any questions or concepts come up, even in the middle of the talk, I'd be happy to address them, you know, in real time here as well as later on. So thank you again to the meeting organizers. You guys have put in a ton of work to put this together, and it's a beautiful series, and I'm honored to be a part of it. So thank you all. So to address this topic, I think we have to cover a few issues, and four main issues I think really deserve some attention. First, what is central nervous system plasticity or neuroplasticity? Second, I think we should talk about how does brain cancer therapy, if we consider multimodal brain cancer therapy, meaning chemoradiation, influence brain function. Third, are there known interventions that promote recovery of brain function? And what do we know about them? And there's a particular interest here focused on cognitive rehabilitation. I'm not a neuropsychologist. I don't play one on TV, but I will give you some I do spend a lot of time with them, and we'll talk a bit about some of the concepts that hold true that we think about in that space as well. So if we're going to talk about function, brain function, and plasticity, we have to really talk about it in context of how we image the human brain. So despite in addition to the advances in neuro-oncology that we've tied together, really in the 1800s, imaging or central nervous system imaging in mammals and animals and humans came into the forefront. You're talking about starting with this basic idea that blood flow is associated with brain function in the 1800s, and then extends into regional blood flow changes related to human behavior. And CT was invented in the late 1970s, in the early 1970s, and so on into MRI. And these imaging studies have really paved the way for understanding how the brain works, both in humans and in animals. MRI changed the game quite a bit. Then adding on to MRI, looking at blood flow in different areas of the brain, particularly whilst a patient or a subject performs a task, has given us these associations and helped us understand, listen, if you put somebody in an MRI and they perform a task and certain areas have more blood flow, at least you know they may be associated. So you get these causal relationships based on fMRI research that's been super helpful. And that led into more sophisticated functional imaging research and then event-related functional imaging as well. But more than anything, I think I really want to talk about the model systems that we use to study the brain, because that's going to come to play when we talk about what we know and what we don't know with respect to human brain function. So again, in order to understand disease and apply these treatments and understanding across different human patient populations, you have to develop model systems. These are ways of studying the brain or ways of studying an organism or a disease that are relatively rapid. And they all have their strengths and weaknesses. And so whether you're talking about studies such as cell culture, where we're just looking at cells in a petri dish, or aggregating those cells together in a petri dish, or growing them in a three-dimensional structure like an organoid to get a better idea of what the organ looks like, or what an organ in a petri dish looks like, or lower level model organisms like fruit flies or zebrafish, mice, and then into dogs. All of these, again, are proxies for understanding the human condition, and some of them are more physiologically relevant. But there's a trade-off between being able to run these studies and understand what they mean for humans, the human physiology, versus understanding and the ability to actually run an experiment to get results in a timely manner. And it's that trade-off that's always in the background of understanding some of the interventions and studies that we're going to talk about here, because many of them are not yet tested in humans, although some are, and we'll talk about this a little bit. I have to pay respect to one important fact here, and that is the human brain versus a mouse brain is very different. This is going to be my last kind of mouse imaging slide here. But again, we're going to talk about some studies and some information that's come from mouse experiments that will seem very promising in humans, and maybe it is, but it's promising with this caveat that the mouse brain is just different. So the mouse brain allows researchers to run a very highly controlled experiment. You can isolate very specific cell types. There's very little differences between mice. You can genetically breed mice that look nearly identical. You have quick access to them, and you can understand the genetics of these mice as well. And you can even look at the brain in vivo, meaning while the animal is still alive, and interrogate it in a very interesting and meaningful way. But the flip side of that is that the human brain has over 1 billion neurons and over 1 trillion network connections, which is very different from the mice. It's highly variable from one person to another, and there's very low cell type specificity. We don't understand with great precision all of the cell types in the brain, and getting genetic access to some aspects of the human brain and humans in general can be a little tricky. So again, you can get very meaningful information using both types, but it's important to understand these caveats. And again, if you just You look, for example, at an astrocyte. We're going to talk about some interventions that may strengthen astrocyte connections. So I wanted to put this simple slide here. You can see a mouse astrocyte looks like this. It has nice connections and nice architecture. But look at a human astrocyte, even so much more intricate and complex. So something to think about as we think about these experiments and interpreting this information throughout the course of the next several minutes. So I think it's essential to begin with a broader overview of how the adult brain maintains normal function and supports cognition and cognitive operations in the non-disease setting, just in the normal setting as we live and age. So cognition or cognitive processing requires both cellular level, meaning from how cells interact, from both neurons, these are the cells that transmit a signal from one to the other, and neurons to glia. Glia are the supporting cells that help the neurons do their job better. And these connections, while collectively establish the synaptic network or the circuits, and these circuits in the brain is really what underlies or what sets the framework for cognition and understanding of how the brain actually functions and communicates from one part of the brain to the other. Throughout our lives, there is some recovery that happens. We call it adaptive neuroplasticity. And that's a process of maintaining healthy cells and their dynamics, predominantly through the hippocampus and a population of cells that are called neuroprogenitor cells, or NPCs. These cells promote the hippocampus and other regions of the brain to make new cells. Another term you'll hear is oligodendrocyte precursor cells, or OPCs. These are the types of cells that maintain the important structural elements of the brain. They make the connections stronger, and they wrap connections with something called myelin. It's these processes that are strongly influenced by the microenvironment of the brain, and they are the underlying mechanism that helps us understand, that helps cognition and helps you maintain normal, healthy brain function. So the brain's ability to reorganize itself by forming new neural connections throughout life is neuroplasticity. So neuroplasticity allows the neurons and the nerve cells in the brain to compensate for injury or for disease and to adjust their activity in response to specific situations or changes in the environment. And intrinsic brain tumors such as glioma is one change in that environment. So again, I have to bring one important point up in the context of this talk, which is that the definition of neuroplasticity in the biomedical science world is much more narrow than we'll use it today. So neuroplasticity, when you read a paper, really involves a functional change that's measured at the protein level or structural level in the brain, using any of the modalities that I talked about in the last couple of slides. We're going to talk a little more liberally about neuroplasticity. The more lay definition of neuroplasticity is any functional recovery or functional change that happens over time. So we're taking a slightly more liberal context to this plasticity term throughout the talk, given the setting in which we're meeting today. So how does cancer treatments or brain tumor treatments or multimodal brain tumor therapies influence brain function? And there are a couple of ways of breaking this up. So I just describe these as glioma. I'm going to use the context of glioma as an example, as a central theme and example for the purposes of this talk. Some of these principles also apply for patients with brain metastasis, and some also apply for meningiomas, but the classic intrinsic brain tumor that changes how the brain works is really glioma. So we'll talk about everything glioma-centric today, and we can change some of the context throughout the course of the question and answer session if need be. So glioma-related functional changes in the brain are thought to occur in the setting of a couple of instances. First, we know that both low and high-grade gliomas infiltrate or invade into the cortex or the surface of the brain and the subcortical regions, the undersurface of the brain. We know that lesions are recreated during surgery to remove the tumor, call it cytoreduction. So tumor surgery removal also create changes in the brain, change the way the brain processes information. And third, we know that our therapeutic interventions, such as chemotherapy and radiation, also influence how the brain functions and works. So I think of them, broadly speaking, as tumor-related brain changes or plasticity and treatment-related changes. And we'll dive into that a little bit more. Over the past 30 years, there's been a growing body of evidence demonstrating that many patients, even systemic cancer, without even having an intrinsic brain tumor, just breast cancer, for example, have cancer-related cognitive impairments. That's the term we use, CRCI. This involves different deficits or changes in memory, language, learning, attention, processing speed, any of these domains outside of that which you would expect as the normal effects of aging. And it's increasingly observed among long-term cancer survivors or brain tumor survivors or any cancer survivors. So like I mentioned, traditionally, cancer-related cognitive impairments and symptoms were thought to be caused by the neurotoxic effects of chemotherapy alone or cancer treatments alone. Therefore, we use the term chemo brain or chemo-related cognitive impairment, or brain fog is another term that was used. However, several related observations have been found that's opened up this definition quite a bit more. And we have them listed here. First, we know that cancer-related cognitive impairments, or just cognitive impairments in general, in the setting of brain tumor, causes a pro-inflammatory, increased inflammation in the central nervous system, particularly in the brain. This systemic inflammatory response is really what makes some cells turn off and not work as well. You can see that with results of chemotherapy. You can also see it with other types of immune treatments for the brain. We know that these changes are associated with a depletion or getting rid of these progenitor cells, these cells that are there to make other cells and be the healthy turnover. So when a certain cell dies, it makes a new one, right? These progenitor cells that are waiting in the wings to make a new healthy, differentiated cell or healthy cell for a function in the brain, those cells die off as a result of cancer and cancer treatments. We know that there are neurotoxic effects of chemotherapy and radiation on mature cells, not just the progenitor cells. We know that often as a result of treatment, you can have white matter injury, you can have white matter changes. White matter is really the scaffold, the structure where the network information transitions itself from one part of the brain to the other. And you see changes in that white matter. It becomes less robust, less thick because of all these processes. And we know, generally speaking, that there's a loss of connectivity across regions of the brain, both at the cortical level, the surface part, and then the subcortical regions as well. So brain-related changes from having a brain tumor can take a couple of different forms. You can have local changes, meaning in the tumor itself. You can have local hemispheric changes, meaning changes in the general area in the neighborhood. And then you can have opposite hemisphere changes that are really fascinating and increasingly understood that we'll talk about in a few minutes as well. And we know that when gliomas are situated within functional regions of the brain, normal processes such as language may be disrupted. And so unlike in stroke models, in stroke models of aphasia, right, where you have a sudden onset stroke and it kills a bunch of cells, and those cells in that whole area of the brain doesn't work as well. We know that in the setting of glioma, there are glioma-related changes that cause a reorganization in the brain. So in this example here, you can see that for a patient who's going to the operating room for surgery, normally this area right here that I'm outlining would be the area of the brain responsible for movement. But we also see here that this region of the brain, this whole region here was involved with tumor. And you see that what happened over time is that the brain reorganized so that this sensory region of the brain took over that function. So you can see that this points 1 and 2 really became the regions for hand function where it should be here. So this was a reorganization or a neuroplasticity response from having a tumor in the brain for many years. The brain itself had reorganized to figure out a new way to get motor responses from a group of neurons to make your hand move in the setting of having a tumor there that wasn't supposed to be there. And so these are, again, local intratumoral changes that maintain function in the setting of having a brain tumor. And these functions are important considerations for brain tumor surgeons when we're trying to remove a tumor and you want to remove it as safely as possible. This is a really busy slide, and I don't want to harp on this too much, but I want to bring one point into clear view. When you think about a brain tumor, many people think about brain tumors with respect to having, think of the tissue as dead, it doesn't function, or it doesn't belong in your brain. But the truth of the matter is that much of the brain is there for a reason. And when the brain reorganizes, sometimes it reorganizes so that there's function in the tumor. So we've studied that a couple of different ways, and I'm just going to show 2 slides on this in this concept. And I'm going to show that if you measure, you can measure neural responses in the brain and look at both tumor regions, meaning regions that are infiltrated with a brain tumor like a glioma, and areas that are not involved with tumor. And you can look and see what the neural responses look like, the amount of neurons that are firing when you have a person perform a task such as speak, when looking at separating out tumor areas and non-tumor areas of the brain. So if you look here, these blue dots represent normal tumor regions and non-tumor regions of brain. The red dots represent tumor regions or glioma-infiltrated regions of brain. And you can see here, this plot is called an entropy plot. It's a way of measuring the amount of information that's encoded in the neurons that are in these areas of the brain. And put differently, you can see that the amount of information that's encoded, I actually use this one, that's encoded within that's embedded within the tumor regions of brain is less, but not zero, where the amount of information encoded within within normal regions of brain is much higher. So both regions actually have information encoded within those neurons. When the neurons fire, they're transmitting information to different parts of the brain, just transmitting less efficiently within tumor regions of brain. And these are important caveats because we know that patients do better with less tumor in the brain. And so surgery to remove is an important consideration, that it has to be done in the context of these important findings so that we understand exactly what we're removing and try to do it the safest way possible. This is another way of looking at this. So you can look at tumor-infiltrated regions of brain, and you can look at the encoding capacity. That simply means that if you have somebody perform a relatively easy task, such as, let's use the naming, for example, and I want to say a monosyllable word, like a pen, and compare that to a highlighter, right? The amount of neurons that have to fire for me to say pen are fewer than the amount to say highlighter, which is a polysyllable word. Within our tumor regions, within the area of brain that are invaded with tumor, those neurons can't come up with enough of firepower to generate the highlighter, but they can come up with enough firepower to say pen, the simple task, the simple part, the monosyllabic one. So you had mentioned all this to say that within tumor-infiltrated regions of brain, there is function in there many times that has to be considered, and you use functional mapping to remove these regions so that we can make sure we're removing the bad part but keeping the good part. But it's not that the function you find within these regions is not as intricate and as detailed as in the non-tumor regions of brain. So again, important considerations when we think about how to safely remove brain tumors. When we're talking about removal, plasticity response or functional responses in the area of brain and in the local region, suppose this is I have a left-sided mass, I mentioned that there are neural responses in compensation or plasticity responses on the right side. And I want to bring to discussion here some work from a colleague of ours, Feroz Darapur, who's a brilliant researcher here at UCSF, who studied this. So in patients with gliomas, it changes in the hemisphere of language function can be seen and can be measured. So again, we know that most people, whether you're left-handed or right-handed, have language predominantly on the left side of your brain, the left frontal, temporal, parietal regions. But this group has analyzed people with patients with gliomas within the left side of the brain and monitored over time what happens to their left-sided function by looking at serial imaging, looking at these neural oscillations, the amount of firing in the brain on both left and right side over time. So to do that, they did whole brain, they measured whole brain activity using, again, speech production, just as a great example. And you could see that, again, the hemisphere of language dominance for most people's on the left side, as you would imagine, as you can see here. But when you measure the amount of people that have a shift in what areas of the brain fire for later on with throughout their diagnosis, it increasingly shifts to the left. So to the right side. So you can see, again, people with left-sided language dominance, the left side of the brain activates when they start to speak, had a shift. Roughly 29% of these folks had changes so that the right side of the brain began to activate. And these changes from left to right occurred again in roughly a third of people, which is a really interesting finding and a big change in the way we think about how the brain functions and reorganizes. So there's even this hemisphere plasticity response where you can have a left hemisphere dominance to a right hemisphere dominance because of your brain tumor and the treatments related to your brain tumor. Now we're in the lookout for what can promote that change from left to right and in ways that we can stimulate and encourage that to happen. And we'll talk about some of those responses in a minute. But that was a really important finding to know that, again, left hemisphere dominant patients can have a switch to the right side throughout the course of their disease. And organically, it's happening in roughly 30% of people, which is a very important consideration, both clinically as we treat patients and with respect to how we think about these treatments moving forward. So there's a really important concept that has to be brought home as we think about neuroplasticity. And again, if we're taking a step back, as we mentioned again, to revisit, the neuroplasticity idea is based on the concept that brain function can reorganize or change in the setting of a chronic problem, like a disease or a glioma or any sort of new environment. This must be weighed against the fact that we know that a certain population of brain tumor cells actually interact with neurons in the brain. And these glioma to neuron interactions are physiologically important and meaningful for the patient and the disease. So we know from the collective body of work from several researchers show that interactions between, this is again a neuron, for example here, and glioma cells drive tumor growth, and feeding back, glioma cells secrete proteins that makes neurons fire more, that results in seizures and other things. So these neuron to glioma and glioma to neuron interactions through both secreted molecules as well as direct connections or synapses is an important part of the physiology of how brain tumors grow. And it's really critical that we think about some of these potential therapies with respect to this. And we're going to revisit this point in a minute as we move further along in the talk. So how does brain radiation, for example, impact brain function? I want to put the disclaimer here that cancer-directed therapies such as chemotherapy and radiation are so incredibly important. And I don't want to take anything away from them. I also want to bring to light some of the important considerations and things that happen to brain cells as a result of these treatments. So we have to balance the treatment with the response so that we can understand some of the cognitive related changes that we see, cognition related changes that we see throughout the course of treatment. So let's use language, for example. And so language and cognitive function are, again, commonly reported as changed following radiation for patients with both low and high grade gliomas. We know that therapeutic radiation, usually the dose is around 54 to 60 gray, depending on the diagnosis. It yields longer survival for patients. We know that. That is very clear. The beneficial effect of radiation, as I mentioned, has to be balanced against developing late cognitive and functional declines. These are the consequences of radiation. The mechanisms are the exact way that radiation changes the brain is not completely understood, but we know that radiation influences white matter changes, meaning the strength of the connections that make one part of the brain or one set of neurons fire with another set is lost or is diminished because of radiation. Again, it's an important therapy, but that's a trade-off that has to be thought about and discussed. In addition to these structural changes, there are cells. Again, these are the precursor cells. In this specific example, it's oligodendrocyte precursor cells, or OPCs. They're quite sensitive to radiation, and their ability to make new cells that make that white matter thicker is really diminished as a result of radiation. So it's really important to think about this. But despite this impact, we see fluctuations in cognition over time. So while these treatments can negatively influence some of the important cells in the brain, there is in repair, and these repair mechanisms play into account and can lead to pretty remarkable recovery over time. So here on the right side of the graph here, you can see how cognition changes throughout the course of treatment. And as I'm looking at this, the font's a little small, but you can see if you lose language as a specific example, and the further to the right you go is time, beginning at baseline or initial diagnosis, and this is out to roughly 27 months. You can see here that during the initial period, patients are doing often well. Following surgery, there's an initial drop for most patients. That decline in function improves. That's the post-resection recovery. And then for folks with certain types of disease, that's when radiation comes in. And you start with brain irradiation, and then you get the post-radiation effects towards the latter half of radiation. And then for the majority of folks, that radiation effect improves back to baseline. And you can see that not just for overall task performance, but in a task-specific manner, looking at picture naming and auditory naming and different elements of radiation, of speech over time. So this fluctuation or plasticity response that you see is really tapping into these mechanisms that organically happen in the brain. The key is, how can we tap into them to promote this plasticity response and help it happen faster, more efficiently, and maybe target it for some patients over another. And that's going to be the next part of the talk here. So we'll cover these last couple of topics here. Are there known interventions that promote recovery of brain function? And again, what does research say about cognitive rehabilitation? And what do we not know about cognitive rehabilitation? And so let's talk about a couple of these topics individually. And I'm going to give a slide per modality. We're going to talk about, I didn't put that on the slide. We're going to talk about a couple of different types of different interventions. We're going to talk about a couple of drugs. We're going to talk about cognitive rehabilitation. We'll talk about exercise. And we'll talk about, again, a graded approach to cognitive rehabilitation. One is a more education telemedicine approach, and the other is kind of in the typical classic cognitive rehabilitation that you would expect and that many of us are familiar with. So, okay, let's talk about neuromodulation. So Actually, let me just look in the chat, make sure. I don't think I'm missing anything major here. I'm assuming, Naomi, you'll stop me if, if there's a question. Otherwise, I'm
Sure,
just going to
yes,
keep
I
going.
will.
Okay,
Yeah.
okay, good. I'm just going to keep going. Okay, so let's talk about neuromodulation. So neuromodulation means that you stimulate an area of the brain externally or internally. And there's a classic type of neuromodulation called TMS. This stands for transcranial magnetic stimulation. The most commonly used approach is navigated repetitive transcranial magnetic stimulation. And this is pretty well studied as a therapy for stroke patients. And it's increasingly explored for patients with brain tumors, including predominantly stroke-related changes for patients with brain tumors. So neurorehabilitation can be supported by these low-frequency stimulations of the, I'm going to use words from the stroke world, so forgive me, but they don't perfectly apply here, but they're written as damaged and non-damaged regions. Again, doesn't perfectly apply in the setting of glioma, but I use these terms. So you can apply a low frequency stimulation to the non-damaged or unaffected side, to which transduces a signal across the corpus callosum from one part of the brain to the other to result in improvement in the affected side. So by this, I mean that, again, one area of the brain is suppressed when another area is moving. We know from the stroke literature that the contralateral hemisphere, the opposite hemisphere of the brain, is involved in the ipsilateral or the same side recovery. And that's just because, again, your brain doesn't want both sides activated at the same time. So it suppresses one hemisphere to allow movement for the other hemisphere. You don't want both motor cortexes, motor regions of the brain kind of interfering and interacting with each other. So this inhibition, one side is inhibited while the other side is activated. And the thought is that this inhibition, this opposite side inhibition, is what stops or slows down the recovery from the ipsilateral side, from the affected side. So the point of transcranial magnetic stimulation is to take away that inhibition. So let me play this out again. If I have a glioma on the right side, or I have a stroke on the right side, the left side of my brain is stopping, to some degree, the right side of the brain from recovering because it's stopping that bilateral activation. So if I stimulate this side, the opposite side, I can stop it from making this side not work well. And this has, again, been studied to pretty exquisite detail in the setting of traumatic brain injury and stroke. And it's now being applied for stroke-related changes in glioma patients. And you can see here's a protocol, for example, by Sandra Krieg and others, and European colleagues, where you can see here that if you take folks with a stroke following a glioma removal, a glioma resection, and you stimulate the opposite side, you can see these folks get better activation of the affected limb at 30-day follow-up in comparison to those who did not have the stimulation. And that was a really interesting finding, and it follows the changes that we've seen the improvements that we've seen in the stroke world. I don't know, what we don't know is whether you could get the same level of improvement for folks who do not have a stroke in the setting of a glioma, those who simply have a glioma or brain tumor that's infiltrated into the brain, into the movement areas, whether the same type of inhibition can also yield a similar type of response. But that study is currently in the process of being formed, and we hope to have that up and running in the next, hopefully in this calendar year or soon after that.
Dr. Hervey-Jumper, there are a couple of questions. Maybe I could just stop you now, if you don't mind.
Sure.
When you were talking about how the non-dominant hemisphere takes over for language, does that also mean that a right-handed person or left-handed person could become a left-handed person or right-handed, or vice versa?
Yeah. So what it means more importantly, or to put a different way, it means that somebody who was a left hemisphere dominant and has a left-sided tumor and now has aphasia, a significant number of those folks have language that's now on the right side of the brain. We don't know how to promote that yet, but we know that that does happen by imaging, as determined by our functional imaging parameters. Whether they become left or right-handed is different. There are people who learn to write with the opposite hand, meaning if your right hand is impaired, you learn how to write lefty. But the function, that's a writing task, the language function does seem to switch hemispheres in a significant number of people, many more than we ever gave credit for. Does that answer the question?
Yes, I believe so. Thank you. And just a couple more. One about neuromodulation. Is that like EEG neurofeedback?
Similar. There are many different ways of delivering neuromodulation. They're broken down specifically into implanted electrodes and surface electrodes. Through EEG, through surface electrodes, you can use transcranial magnetic stimulation, called TMS, as I described. You can use something called TDCS, and you can also use high density EEG to deliver your current. Either way, the effect is you are stimulating through the skin, through the skull, a population, centering on a population of neurons to get those to supercharge, to release their neurotransmitters for a desired effect. That's neuromodulation.
Got it. Thank you. And another question here. Over what period of time are the long-term effects of radiation seen on cognition and language?
Yeah, great question. It can be years. It can be years. So they're not immediate effects. Usually you're talking months to years after the treatment. And there, again, I should say there is recovery for the vast majority of patients. And it depends upon the volume of radiation, the age of the patients, other comorbidities. But the effects that you see can occur years later, not days to weeks to months. Okay.
Great. Okay. There are a couple more, but you might be answering this as you go along. So maybe I will let you go on and we'll
Perfect.
visit. Okay.
That's great. Yeah, that's much more fun. Nobody wants to listen to themselves talk for 45 minutes. That's painful. So thank you for for asking some questions. So there's an important study that came out earlier this year in the journal Neuron, and I want to bring this this psychedelic drug to the forefront to talk about. In the short, and this specific slide is the whole reason I wanted to show the difference between the mouse and the human brain. Okay, so psilocybin is a really interesting psychedelic drug that's showed promise in the treatment for depression. And this drug is actually, because of its potential as a neuroplasticity modulator, meaning promoting plasticity, has gained some attention. There's some really important considerations to think about. So we know that in depression, because I should say that the context for this study was largely in the setting of depression. You know, one of the changes that happens in the brains of depressed animals, and we think humans, is that the number of neural connections, the number of synapses, becomes smaller, becomes less. So the increases in the density and strength of the neuronal connections may be an underlying, may have underlying impacts on behavior. And this drug is potentially a way of rapidly improving those connections. So this psychedelic drug has, again, gained some notoriety because we believe it's a way of, at least in the brain of a mouse, making or promoting new neural connections in the frontal cortex of mice. It may have a role in depression research. We know that within 24 hours of using this drug, researchers detected or found an increase in the number of dendritic spines. That's these little things here. I don't know if you can see it on you can see it here. So this is a dendrite, and you can see these little bulbs, these little puncta. These are synaptic bulbs at the end. These are the actual structures that make the connections from one to the other. These are the connection points that transmit a signal. And so the researchers were thrilled to see that they saw an increase in the number of these dendritic spines, both with respect to their size and their density. And these changes happen quickly, or much quicker than they expected. And so, and they measured 1 month later, a small number of these new kind of changes were still present. making them think that maybe these changes can be long lasting. So again, not only were 10% of these cells, of these changes still there, but they were there and even larger when they first looked at them. So this drug, again, is a potential way of modulating or changing the nervous system in a way that's drivable or inducible. Couple of really important points here. These are important interaction. There are really important interactions between brain tumor cells and neurons. And we know that, again, supercharging a neuron, making a neuron fire, can actually make some brain tumor cells grow faster. So though this therapy may be helpful or potentially helpful for making new connections, which showed in this mouse model of behavioral change, those new connections could have the exact wrong effect in the setting of brain tumors or brain cancer. So increasing the number and density of these connections, the effect of that is really unknown in the setting of, for example, glioma and certain types of brain metastasis. So there definitely needs to be preclinical and clinical experiments, meaning experiments in both mice and humans, to flesh that out and to understand what might the effects be before that could and should ever be tried in humans. I would definitely not recommend this treatment at this point, but it is an important consideration and something to think about as a way to drive the nervous system to make more connections that could help cognition, but again, with the caveat that it could have bad effects on tumor growth if we don't understand the process well. Next drug, metformin. I'm not sure how much press this has gotten, but last year there were two really important papers that came out, both in Nature Medicine. Again, just to revisit this, we know cancer therapies, including cranioradiation and chemotherapy, cause dysfunction, right? They cause a number of changes, including the precursor cells, these NPCs, these cells that make mature cells that do the important functions in the brain. They become stunted. They just kind of stop working and or die. We know that. That's one of the challenges or problems with our cancer therapies. They disrupt this normal pathway of making new cells. Some preclinical studies, again in mice, show that metformin, which is a drug for blood sugar, promotes new precursor cell formation after a brain irradiation in mouse models. So this group asked whether pharmacologic stimulation of these precursor cells would promote cognitive recovery and repair, again, focusing on this metformin drug, and they ran studies parallel in mice and humans following radiation. The humans were really children post-radiation, and they showed, again, in the cranial radiation model, that metformin enhanced or promoted the recovery of these cells, particularly in a really important area, the dentate gyres, which is an important hotbed for where these new cells come from. There were some sex-dependent effects, male versus female, on this effect and cognition that was really important. They also ran a double-blinded placebo-controlled crossover study. This is a clinical trial of survivors of pediatric brain tumors that were treated with cranial radiation, and they just showed a feasibility study. So again, these are 24 participants. They were treated over a 12-week cycle or 12-week period with metformin versus a placebo drug. And they showed roughly a 10-week washout period. And for a subset of patients, they found that metformin was associated with better performance than the placebo drug on a couple of different types of cognition, particularly memory. A couple of different types would work, declarative and working memory to be specific. This was really strong evidence, or really provocative evidence, that this type of drug, like metformin, may have a role in treating cancer-related cognitive impairments. Now, this was tested again in mice and human in the setting of chemoradiation-induced changes. We don't know a couple of things here, right? The pilot study did not show the efficacy, meaning this is feasibility. It didn't show how effective each dose was at getting this response. It also didn't look at what type of tumor growth happened during this period. The human studies were all in patients with long-term survivors of pediatric cancer with stable disease, not in people with active disease. So we don't know what would happen if you tried the same approach for people with active disease or residual tumor. So again, important caveats, really promising. This involves both mouse and human data. Again, just I have to say this again, I'm not a neuropsychologist. I don't play one on TV, but I want to bring home a couple of important topics about cognitive rehabilitation. It's just such an important therapeutic strategy. We know that a multidisciplinary cognitive rehabilitation program is really the standard of care for addressing cognitive impairments in many neurologic diseases and conditions. And it's been with promising application been applied for patients with brain tumors. And I'm thrilled that Laura and some others probably in the audience have interacted with our neuropsychologists and had great results, results in general. There have been a number of studies that have pointed to how promising this is. There is a prospective randomized study a couple of years ago that offered roughly, I think it was 6 to 8 weeks. Most people completed 8 weeks of intensive outpatient rehabilitation versus a kind of watch and wait approach as a control group. And there were improvements noted in many of the psychosocial interactions and communication, attention, memory, problem solving, etc. And that was seen in patients maintained out for about 6 months. So a really durable response. And that was actually 6 months was the end of the study. So it's really important to consider cognitive rehabilitation, should be considered probably during certain periods. We don't really completely understand exactly when it's best applied. Probably best considered during periods of both mental stability, disease stability, psychiatric stability, but it's possible to apply it in other conditions and other time points. But that's an important caveats in area of study that are not as well understood. Again, important take-home points: screening. As providers, it's important that we screen our patients to understand who is having changes and challenges that would best benefit from evaluation with a cognitive rehabilitation specialist. Managing comorbidities are really important. Having diabetes, blood pressure, blood sugar, management are really important. Talking with your doctor about how you're feeling as a patient is critically important. And again, the optimal timing of treatment at this point is unknown, but something we hope to understand better in the future. And there really is no consensus on what type of cognitive rehabilitation program is best. There are a number of different types. I'm going to not go through that because we have excellent neuropsychologists that can be much more elegant, give a much more eloquent discussion about that than I can. But it's an important area of study with a lot of literature that suggests that it's of benefit. I love the study that I want to promote by Karen Gehring and her team in Europe about exercise. So again, we know that patients with glioma suffer from cognitive deficits, as we talked about. Exercise has been effective in ameliorating and limiting the effects in older patients and many patients with neurologic conditions. And this is a study that used a pilot randomized control clinical trial for patients with for exercise with glioma. These are glioma patients. So they took this was 34 patients with stable disease with grade 2 and 3 gliomas, and they were randomized to either an in-home therapy physical exercise program for 3 times per week for 20 to 45 minutes per day per encounter, with moderate to vigorous intensity for 6 months. And I should say exercise was self-reported. There was nobody peeking in the window to make sure. And when they looked at linear regression or looked at correlations or changes that were associated, they found really nice 6-month improvements in a number of different outcomes, particularly outcomes related to how the patient is feeling, what we call patient-reported outcomes. So you can see here in the exercise group, there was at least small to medium-sized benefits. If you look at this graph here, all of the up arrows the up bars are improvements. In the intervention group, the exercise group, which are the dock bars, you can see here that these are all different types of attention domain. Attention processing means the ability to ignore irrelevant distractors and focus on what you're doing or what's going on in front of you. You can see that, again, just using this as an example, since I didn't want to make too busy of a slide, really, really important gains in a number of different domains for folks who completed the exercise program compared to those who did not. So this really suggests that mild to moderate exercise can really help your brain rewire, and you can get some really nice functional recoveries from associated with it. And this is in addition to improvements in fatigue and sleep and mood and kind of the other mental health benefits that came with exercise as well. Okay, let's see, we have a couple more minutes. Okay, so actually I'm way over. I'm sorry about that. I'm over time. So let me finish.
That's okay. This is so interesting.
Oh, sorry. Yeah, you didn't stop me. I'm way over time. Okay, so a couple of last slides. So there's for my patients, a lot of times this idea of brain games comes up, or luminosity, or some of these other remote rehab strategies comes up. And I think they show some promise, but again, there's some caveats that should be considered. So there's a great example here, again, by one of our UK colleagues about cognitive education and tele-rehab, and this one is called Remind. So this is just one example, but this is a group that took their inpatient cognitive rehabilitation program and they distilled it into almost like a app, basically an app that you can use on your phone or your iPad. And they ran a large randomized controlled trial to see how patients did. Now, keep in mind, this trial did not determine efficacy. It simply determined the feasibility. Could patients complete the intervention? So treatment started 3 months after surgery. Patients spent or were advised to spend roughly 3 hours per week on the program for 10 weeks. And again, they saw that on average, 71% of people participated and they remained active. It wasn't everybody, but 3/4 remained active. Most people, patients that are involved, rated it as a good experience. 85% of the folks who participated rated it as a good or excellent experience. And this was a really important proof of concept study that showed that maybe with some effect, we can deliver some cognitive education or tele-rehab services through remote, because it's not always feasible to have inpatient cognitive rehabilitation with a specialist. There's access issues and a whole host of other issues. So again, we don't know yet what the efficacy is and how the tele-rehab approach, the cognitive education approach, compares to the inpatient approach, how they compare head to head. There's some ongoing studies, including ours at UCSF as well as others. But we do know that it's very well received by most patients and a really important consideration and something we should think about, or many people will think about moving forward. I apologize for being way over time. I just want to say for all the patients and families, I know this is really a patient-facing event. Thank you for partnering with us to study all these important concepts. You guys are at the center of all of this. Clinicians, researchers, industry, we're all putting our heads together to try to make life better, and make the disease more manageable and help everyone maintain the healthiest possible quality of life and promote brain health. So with that, I am going to quickly stop sharing before Naomi never invites me back.
No need to apologize. No, that was so interesting. And I really appreciate it, Dr. Hervey-Jumper, for just your wonderful overview and helping us understand a really complex concept. I think there are more questions, and maybe if you are able to stay around a little bit later, we would be able to address some of those in the after the show or the Q&A period. So thank you. So we'll bring you back on later if we can. And as a reminder, if you want to submit your questions during the Q&A, please do that. We're not sure if we can get to all the questions, but we will try, and maybe we can do some more with Dr. Hervey-Jumper and after the show. if you can stick around. So now, however, it's my absolute pleasure to bring on one of our survivors, or thrivers, as we like to refer to our survivors, Laura Grantham. Laura is going to come on with us here and help us understand this topic and what it means from a more personal perspective, as she has rehabilitated herself after her brain cancer treatment. So Laura, I'm so appreciative of you being here. Thank you so much. And I'd love to start off, if we could, just by asking you, could you just share with the audience a little bit about yourself and how your cognition changed after your medical treatment?
Yes. And thank you. Thank you for allowing me to share my journey. And thank you, Dr. Hervey-Jumper. This was one of the most fascinating things I've ever heard. So I very much appreciate you sharing all of that with us. So I was actually diagnosed with a brain tumor in 2019. I found out just by, passing out, hitting my head and having to have an MRI, and that's how they found the brain tumor. A few months in, we were able to find Dr. McDermott, and he removed 95% of the tumor. So following the surgery, a few months later, I had to undergo some radiation, some other, kind of surgeries that we had to do, but nothing major. And, from there, it was just a lot of, kind of figuring out the recovery and how to manage that.
Thank you, Laura. So what did you notice about your cognition after treatment? What did you notice was different?
Yeah, it was pretty intense. I couldn't remember things. I couldn't say full sentences. And memory and full sentences was the main thing. I was having a hard time following conversations. I was having a hard time even thinking, I guess. When people were talking to me, I couldn't comprehend what they were saying. That was pretty scary, actually.
Yeah, I can imagine. Mm-hmm. And so how did you get to ask for help? How did that come about, and how did you get help? What help was it?
Yeah. It was really interesting. Dr. Bush at UCSF took over as Dr. McDermott had moved on. And so she actually noticed that I was having trouble following what people were saying and saying full sentences. She definitely noticed that. She also could see how frustrating it was for me. So she actually referred me over to the program with Dr. Jamora, and it took about 6 months for me to be able to join in this program, because that was right when COVID hit. And so that put a little halt on that. And I really didn't know what to expect. But during that time, I wasn't getting better, but I also wasn't understanding what was going on. I thought it was on me. I was putting all the, blame on myself. I just didn't understand there was a process, and I just didn't know that. And so being hard on myself and kind of isolating myself, falling into a depression. And I knew none of this. You don't really know. Your brain isn't working the same way. So that was, a lesson to learn. And Dr. Jamora really was incredible. I couldn't say enough great things about her in this program.
Yeah, and for those who don't know, Dr. Jamora is our neuropsychologist in the cognitive care clinic at UCSF. So, so tell me a little bit about working with Dr. Jamora and cognitive rehab and testing. Can you tell the audience what that's like? What does that involve?
Yeah, definitely. There was in-person testing, and it was really just seeing how my brain was working. And so a lot of different tests. From there, she was able to, kind of put together a plan for me Everybody is different. So she really takes the time to find out, where some of your challenges are and, how to help you through that. So after the test, she just really takes the time to get to know you, and kind of ease you into this program. It can be overwhelming or intimidating, because you don't know what to expect. You're just so hard on yourself, and having somebody kind of tell you that you're doing great, it takes a minute for you to believe that. So she really has a nuanced way of getting you to that point.
Yeah, great. Yeah, you had said before that you were really hard on yourself. You were, just kind of putting it all on yourself, and you were isolating yourself. Did cognitive rehabilitation help you with that? Did you see things differently?
Yes.
Yeah.
Very much so. So we got my depression under control. She referred me in, and once we were able to get that depression under control, we really could focus on me. And, it was really, she had a way of empowering you, and being okay with not being okay.
Mm.
Yeah.
Yeah.
And this isn't a cookie cutter kind of program. She really designed it around me and my needs. And we had to adjust. Some things weren't going to work, and we figured that out as we went. And I think that was super therapeutic because, it allows you to be not perfect. And you kind of learn as you go. And that was a really good learning experience, whether intentional or not.
Yeah. Great. So in terms of anything that's changed or improved, what have you noticed?
So I would say, I think before rehab, I really didn't trust myself to do pretty much anything. Decisions were hard. I was always second guessing myself. Somehow through the therapy, that just is gone. Now I'm okay with making mistakes. I actually feel good about it. I feel like I'm learning every time I make a mistake. And Dr. Jamora got me there. We had setbacks. And after a while, those setbacks, she allowed them to be a really great experience.
Wow.
Yeah. Yeah. So I learned that from her. And now if I do something that, kind of goes back to maybe how I was before, I kind of can, I don't want to say laugh about it, but I can say, okay, that's a learning experience, and really look at it that way. I do not get down on myself at all anymore. I'm back to my kind of happy, positive self, which is really great. And I think with the brain functioning that changes, it's not just the brain that changes, it's the perception of yourself. You really have to understand that this is your new normal, and that's okay. Your brain doesn't work the same way. And you just have to understand that it's not wrong. It's not doing the wrong thing. It's just different.
I love that. Not wrong, just different.
Yeah.
Yeah, that's beautiful. And so could you give us just an example of kind of maybe a practical thing, like what you were doing to help with your cognition? What's something practical that you were doing that was really helpful?
Yeah. So initially, I was having Post-it notes everywhere. And I didn't want that, but it was a good way to kind of identify where I needed the Post-it note. So anytime I would forget to do something, I could put a Post-it note there and realize that that's one of my hurdles. And once we got those identified, we were able to find different ways of working through that instead of the Post-it notes as a reminder. I like to sing, so I could, sing anytime like I was going to go do something. I would walk into the kitchen and forget what I was going in there for a lot. And so I would if I was going into the kitchen, I would sing, I'm going, sing a song. And so that was therapeutic in itself. I also found this app called Otter. And I don't know if anyone is aware of this, but it is the best app. I would always think of things either when I was going for a walk and I didn't have a notepad to write it down. So I would use Otter. You can speak to it and take notes. You can also create tasks. And so that was kind of my Bible. Because by the time I would get home, I would forget what I remembered. So yeah. I also got a pill organizer so that I could make sure that because I would forget, did I take it? I don't know. And so that pill organizer showed me that yes, I did, or no, I didn't. And then I got rid of all the Post-it notes. I think this is the most important one, even though it sounds silly. The Post-it note that remains is progress over perfection. It's a reminder of that, and I like it.
So you have that written down by your computer or something?
It's progress on the computer. Yeah.
Yeah. Progress over perfection. I love that. Mm-hmm. I love that. Yeah, I can really see how you are not hard on yourself now. You're taking mistakes and you're just using them as like fuel for learning. And it's lovely.
It's like night and day.
Yeah.
Because I had isolated myself, that could have been very damaging long term to my well-being, as well as my friends and family. And so now I'm able to open up to them. When I need help, I can ask for it. And I'm not, worried I'm going to be a burden on them.
Yeah.
It's made my relationships better.
Wonderful. Well, thank you so much, Laura. Is there anything else that you want to share before we have a few more minutes for questions?
The only thing I can say is like this program is incredible. I'm so happy that I was introduced to it and grateful. Yeah.
Thank you. Thank you so much. And thank you for your honesty and sharing with all of us so we can all learn kind of what it's like from a more inside out perspective.
Yeah. Yeah, I hope it helped.
Yeah. Thank you. Thank you. So if you could stay on a little bit longer with Dr. Hervey-Jumper, I'm going to see if there's any more questions, and we have a few more minutes for that. Let me see. It does look like there's some more questions here. I'm not sure if we can get through all of them, but let's see. Where are we here? Okay. All right. This is getting back. I think, Dr. Hervey-Jumper, we have some questions for you if you are able to come back on. Thank you. We have a question here around in the third of patients whose language center shifts. Was that shift associated with increased language skills recovery? Are you able to speak to that?
Yeah, great question. Unknown. Okay. These are only the folks included in the study had maintained language. So by maintain, that's typically defined by no significant change from baseline. So, but we don't know what their new baseline is, right? So these are all by definition after the brain tumor diagnosis. So I don't know how that relates to before, but they did have maintained language function at least. But whether it improved to their pre-baseline standard, I don't know.
Okay, thank you. And someone is asking if they could get a link to the Remind app that you were mentioning. Is that available?
Yes and no. The Remind app is actually a proprietary property of the university that created it. But Ginny Taylor and Chris Warjamora are principal investigators of the longitudinal clinical research study here at UCSF, and one arm of that study is use of the Remind app. So we could give them a link to, I don't have my computer open anymore, but we could give them a link to the LoglioCog clinical trial or clinical study and see if they meet eligibility for enrollment. But the Remind app itself, I do not think is publicly available for use yet. I think it's mostly a research tool.
Got it. Okay, thank you so much. And if we don't get the link in the chat here, we'll make sure that we send that in a follow-up email that we will get to you in a few weeks, or a couple weeks, hopefully. So thank you. So I'm just going to go back to a couple of questions around the neuromodulation when you were talking about that. And someone is asking about when you have titanium plates, does that still work?
Great. You guys are awesome. Yeah, really good question. So it is not an exclusion criteria for study enrollment. Whether it's still of the same level of efficacy as, as bone is hard to know, but you can be still included in the study.
Okay, got it.
And you mean titanium plates to keep your bone together. So I see what I was thinking some folks have a titanium cranial implant with the bone is replaced by titanium. If you're talking simply about the plates and screws that hold your bone together, it absolutely works fine in that situation.
Got it. Thank you. And then a similar question around Optune. Some of our patients use Optune, and does that interfere or enhance or get in the way of the neuromodulation or other therapies that way?
Unknown. So if you look at the amount of electrical stimulation delivered through Optune, it should be far less than you would expect to see. It's far less than that's delivered for TMS or TDCS, any of the standard neuromodulation devices and treatments. So there may be effects. The effects are probably pretty minor because the amount of electrical stimulation that's delivered through the brain, most of that is probably not actually reaching the effector cells. But again, that's my interpretation of that. That study has not been completed.
Okay. Thank you so much. Laura, we have a question for you. A person is saying, Laura has given me real hope. What she's sharing is fantastic, especially because I relate to so many of the frustrations and deficits you've worked through. What I'd like to know is when she faces a frustration or makes a mistake, what does she do to get through that or deal with that or overcome? So how do you deal with that?
Thank you. Yeah, that was really tough. And I have to say this program really helped me with that, because every time I would do something wrong, I would say, oh, I'm so stupid, or, really criticize myself. And Dr. Jamora really steered me away from that in her gentle way. And, now when I make a mistake, I actually say, well, that wasn't right. Let's not do that again. Maybe try this time. And I have a conversation with myself, which I think is okay. And so I talk myself through it. And, some people journal, that doesn't work for me. So apparently I like to talk to myself. So I talk to myself.
And you like to sing too. So
I do. I like to sing. So I guess, that audible is impactful for me.
Yes. Thank you so much. Yeah, I'm hearing like when you make a mistake, it's almost like the brain is kind of, you're helping the brain find a new pathway too. It's like,
yeah, or the brain is helping me.
Yeah.
We're helping each other. Yeah.
Right. It's all learning.
Yeah.
Thank you. Thank you so much. Well, I know that we are at time right now. I know we haven't gotten to all the questions. If you can stay around after the show, that would be lovely. But if not, and we'll see what we can do in terms of getting some of the questions answered and sending it to you in our follow-up email in a couple of weeks. I want to thank you so much, Laura and Dr. Hervey-Jumper, for your excellent presentations, for really helping us understand this really very important topic. And I know we're going to want to have you come back, Dr. Hervey-Jumper, to even explain more. It's so fascinating, all these different areas. So thank you so much. So for those of you who are able to stay with us, I will let you know how to do that. For those of you who are leaving us now, I want to thank you so much for joining us, and I hope that we see you soon at a future webinar.